So this will increase the size of the lens. What's the mechanism? Some of you said a pupillary block. Yes, this is one way of inducing phacoemorphic glaucoma, or lens size can induce secondary angle closure glaucoma by pupillary block. But again, if the lens is too large, it can directly tamponade the iris against the angle, so either by pupillary block or direct closure of the angle, or both of them. And this is the most of the occasions is the both of them, that the induced glaucoma is due to first pupillary block, second direct tamponading of the angle, giving the classical form of phacoemorphic glaucoma. Or the lens can be a cause of glaucoma due to its site. Such this lens, as you see, it is not a normal place. This is dislocated lens. Oh, sorry, subluxated lens. The lens is not fixed. So subluxated or even dislocated, as you see here. The lens subluxated in the posterior chamber. Here the lens is dislocated in the anterior chamber. So this, and the mechanism again, direct angular closure glaucoma, as the case in the first situation where the lens is subluxated, mobile or semi-mobile lens. So if you slept on the right side, the lens will go and tamponade the iris against the temporal side of the angle, and so on. So it is a mobile lens or semi-mobile lens, so inducing a direct tamponading of the iris against the angle, and this is the most common type of subluxated lenses or lens-induced glaucoma by site. Rarely, this lens may escape, and if it is totally dislocated or there is no much granules, can dislocate to the anterior chamber and cause acute form of glaucoma. This one is usually chronic form. So direct angular closure or pupillary block if the lens be at the level of the pupillary aperture or went to the anterior chamber. So will cause a pupillary block, acute secondary angular closure glaucoma. So then the conditions that related to the lens material, always they are of open angle type. So either due to lens protein glaucoma, in the past they were calling it a phacolytic glaucoma, pointing to the macrophagic response engulfing the lens protein. However, as you will see later, the situation or the mechanism is not due to the swollen macrophages, but due to heavy molecular weight lens proteins that leaked through the capsule with micro holes in the capsule. And then related to lens material, also lens particle glaucoma, not the lens protein soluble one, but chunks of lens matter tamponade directly the angle and lead to elevation of the intracarpation cord called lens particle glaucoma, and there is a big difference between lens particle and lens protein glaucomas. Mechanism again, blockage of trabecular meshwork by lens particles, retained lens material, or after YAG, posterior capsulotomy. This is one of the major problems or complication of YAG posterior capsulotomy, is the acute elevation of intracarpation, as you will see later on. So let us take one by one. Phacoemorphic glaucoma. It's more common. It's smaller eyes, hyperopic eyes. However, it can occur in anemetropic eye or even in myopic eye. But it is more common in small eyes or hyperopic eyes. This is very important. It is a major problem still in a country like ours. It's not as when I was a resident. We see it frequently, probably I will not say on daily basis, but we see 3 or 4 cases per week. But now still we see it from time to time, but not as before. Again, it's counted in more in developing countries such ours, although we are now a little bit higher than that. Predisposed by, as we said, rapidly developing intermittent cataract and traumatic cataract, and the mechanism is as follows. The lens gets swollen. The lens gets swollen. Swollen lens lead to pupillary block, and then iris Bombay. So we are talking about a pupillary block mechanism of lens-induced secondary angle closure glaucoma due to the size of the lens. And this will lead to angle closure, or, as we mentioned, the lens swollen, it is too large, can lead to direct tamponading the angle, causing angle closure. Or, as we mentioned, both conditions working together. So this is the problem. If the lens is large enough, and probably the eye is hyperopic small, can cause pupillary block as well as direct tamponading of the angle or direct closure of the angle. So this is very important. This is again the UBM of a patient with, you can say, a thecomorphic glaucoma or swollen lens, or even you can say the same picture in acute primary angle cardiac glaucoma. There is a pupillary block, large posterior chamber, and the iris is pushed against the angle. So this is the usually, although in thecomorphic glaucoma, especially in narrow in hyperopic eyes, you wouldn't expect it to see such a large or posterior chamber. So stages of the thecomorphic glaucoma, pupillary block, as we said, crowding of the angle, chronic angle closure glaucoma, and as you see here, the clinical picture, as we mentioned earlier, it's typically, if there's no lens, cataract like this, I would say this is an acute primary angle closure glaucoma. So it behaves like acute primary angle closure glaucoma. It is an acute congestive glaucoma, an emergency type of glaucoma, present to the emergency room, patient complaining of pain, heavy, very, very bad pain in the eye, and probably sometimes headache, sometimes similar to acute congestive glaucoma, even sometimes vomiting and nausea and so on. Midday, the pupil, shallow anterior chamber, closed angle, of course, if you're able to gonioscope the patient, or even when you do the gonioscopy on the other eye, will see it a narrow angle, and the vision will give you a history that his vision was deteriorating over months or more, but of a sudden became very faulty light projection that probably many factors, pain and headache and so on. So he would say that sometimes you'll see, yes, light projection, he can give a good light projection, sometimes he cannot. So we'll give faulty light projection. So as we said, gonioscopy of both eyes is very important. Ultrasonography is extremely important. Is there anything in the clinical picture, the high IOB, shallow AC, closed angle, even in myopic eyes, if developed a thecomorphic glaucoma, you will see, due to the pupillary block, you will see shallow AC. So when you do the diagnosis of thecomorphic glaucoma, the clinical picture, as we said, the gonioscopy, at least of the other eye, it will be very important, but it is very straight ahead, clear to diagnose on clinical basis. Why we do ultrasonography? Why we need? I feel ultrasonography as a board exam and such a thing, if you couldn't tell me or you escape the ultrasonography for such a patient, probably will not be an ophthalmologist. Why? Why we need to do ultrasonography? Rule out what? Huh? Like what? Like what? Humor. I don't care about detachment or whatever, but humor. I remember when I went, probably in the fourth year, during my residency here in this building, in this hospital, Dr. Torbak presented a case of similar to this case. He said, okay, we said, oh, this is very, this is very thecomorphic, this is very clear thecomorphic glaucoma, and this we need to go to see if we can go for cataract extraction alone or we combine it with it. Blah, blah, blah. Then it appeared that case that there is a tumor inside the eye. So ultrasonography is a must to be done in such situation. Paracentesis, it is for academic purposes to see if there is, for example, inflammatory cells, type of inflammatory cells there, is there a malignant cell or whatever, but it is not in a practical setting. Management of such a glaucoma, medical treatment to lower the intraocular pressure, and then frequent topical steroids. These eyes are very angry eyes, so we need to quieten the eyes. And Bilocarbine, also, the pupil is mid-dilated and the sphincter pupillary is ischemic almost, but it may work. And then laser iodotomy, it is the first step from surgical interventions. And then the different treatment is cataract extraction, whether with PCIOL or in long-standing cases, we need to go and combine it with glaucoma surgery. How do we judge? We say, that we need a trabeculectomy or not? This based on the clinical evaluation after the initial treatment medically and with laser. So we need to evaluate the case. We shouldn't rush for surgical intervention or surgical removal of the cataract to see. Of course, there are many players in this situation, the duration, the status of the IOP after initial treatment, although in acute cases, we shouldn't be fallen by drop of pressure because the eye is inflamed and there is aqueous suppression, cellular body depressed, or it's not forming aqueous in a regular way because of the inflammation. So we need to evaluate and to see the angle if we can do gonioscopy and so on. So there are many things that you can play with it, or you look at it to decide whether you go for cataract extraction alone or with a trabeculectomy. And of course, we shouldn't forget the other eye. Advantage of laser, I wouldn't spend much time there. Of course, you leave the acute attack, allows eye to quiet pre-op and evaluate the patient, allows evaluation of the angle, allows safe pre-op mydriasis if the pupil is going to dilate. So, and I remember, and probably I told you before, one patient developed acute angular choroidal glaucoma in the holding area. Before we give the block, she developed a pupillary block. The pressure was at 50. We delayed or we postponed the surgery. So in presence of patent PI will probably help in preventing such an attack. So risk of iridotomy, of course, bleeding, endothelial injury, if this is our shallow chamber and so on, rupture of the lens, although this is not a big deal for me, and failure. If there's failure, they couldn't do a peripheral iridotomy, you just gain the inflammation of the procedure. So intraocular difficulties, this is very important and very really challenging situation when you deal with a phacoemorphic glaucoma due to many things. Difficult capsulotomy, fixed and mid-dilated pupil, you need to manage this. Shallow IC and positive vitreous pressure, in most cases, poor review due to corneal edema, desmoid detachment, and weak zenute. So how can we overcome this? Poor review, of course, we can, corneal edema, we can give glycerin, we can give mannitol, we can give many things, or even you can scrape the epithelium. Most of the time, the corneal edema is due to epithelial edema, not stromal edema. So you may improve or you most likely will improve the view. So fixed mid-dilated pupil, again, this is not the major issue. Mechanical mydriasis by viscoelastic, by pupil dilator or retractors, or even small sphincterectomies or sector iridectomy. This is what, before the phaco era, when we were still in the beginning of our residency, what we do, we go and do sector iridotomy and dilate the pupil. And in our population, this is not a big deal because we are having a colored iris, dark colored iris. But in the West, with lighted pupil, colored pupil, this will disfigure the eye. It will be very clear. So it is not acceptable, probably, unless you suture it at the end, which we were doing such a thing anyhow. So you need to manage the pupil, and this is not the only thing. But again, the difficult capsulotomy. You have a patient like this. I don't know how can we do capsulotomy in such a patient. Even if you go, the eye there is something abnormal in the eye, an abscess in the eye, like abscess. You cannot, deepening of the chamber of viscoelastic material through the paracentesis. This will lead to prolapse of the iris and so on. The chamber will not dilate because there is a mass there. So what we will do, puncture the lens. Yes, this is a possibility. You may succeed to aspirate the liquefied cortex and have a better chamber. But this is, again, an easy measure. This is what we were. This is one of our patients, by the way. So how can you, do a capsulotomy from the chamber in such a situation? This is not an easy thing. So we need to do something. So Difficult capsulotomy, as we said, because of so on. So what we do, and this is I learned from my teacher, Dr. Karim Toma, do a simple vitrectomy, blindly. Retina people here, they will get, they will say, oh, what is that? So, yeah, you can go 3.5 millimeter probably to 4 millimeter if it's such a swollen lens. And as we're doing injections for intravitreal injection from the phlebitis, you don't see the needle, you don't see anything, so you go blindly and inject. And of course, you need not to inject the whole needle or to introduce the whole NVR, so you need say 6, 7, or less even millimeter, then put a homostat and go directing the knife or the needle toward the optic nerve head, and then go with the cutter only. With the cutter only, the vitrector, you don't need irrigation. Tuck, 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 3, 4 times. This will soften the eye, will take some of this, or debulk the eye. You are debulking the eye. Then you will find the eye soft. You can deepen the chamber. You can do whatever very easily. And this is, it's not, infrequent to have it in the past from time to time. So it is very helpful. Triban blue, of course, for capsulotomy and these things. And even if you are going to do extra capsule color extraction, you can go with if you are working supine position, you go and make sure that you are cutting or doing capsulotomy time opener in this 12 o'clock position. So, and most of the time the lens is not that big. So the nucleus, so you do make sure that it is really, there is nothing from the capsule remaining strands to prevent the nucleus when you want to deliver it. And then you can deal later on with the rest of the capsule, anterior capsule. You can cut it with a scissor, or you can do it as a rectus way, whatever. So this is very important. This is with detachment. I will not spend much time, but you have to be aware that the eye and the edema of the cornea, it may facilitate this with detachment, so you have to minimize your exit and entry of the anterior chamber, especially with sharp instruments. So then we'll come to another type of anything in the phacoemorphic glaucoma before we leave it, or we can discuss it at the end. So the other type of secondary angular closure glaucoma caused by the lens due to its site is the subluxated lens. Subluxated lens, as you see in this patient, it is in the posterior chamber. So as we mentioned, it's mobile lens. It can tamponade the angle, can press the iris against the angle, inducing peripheral anterior synechia from time to time. Then the pressure will elevate. Usually it doesn't present to the emergency room. Most of the time present to the clinic because of the chronic building of the intraocular pressure. So the patient probably has all his complaint is visual complaints due to the bisecting the pupil or so. So we need to, when we look such a thing, we need to know what's the reason for this ectopia lentis. We need to be familiarize ourselves with the causes of ectopia lentis, like trauma, like Marfan's, high myopia, pseudoexfoliation, mature cataract, and so on. So lens can subluxate into the anterior chamber, and this way, as we saw before, here the patient will come to the emergency room because of the pupillary block and sudden rise of the pressure and pain and associated other symptoms and signs. So in this case, there is a recurrent elevation of the pressure and formation of the prefrontal synechia leading to disc damage, corneal injury, and so on. So, and the treatment of such a thing is to go for, if it is a posterior chamber, you can give miotics and do peripheral iridotomy multiple, but again, this will not prevent progression of the lens because it's not a pupillary block mainly, but due to the BI is to prevent possible pupillary block if the lens reach the pupil margin or dislocate anterior chamber. So, but here is the different treatment is to remove the lens, whether through the brass plana if the patient, if the lens is in the posterior chamber or posterior segment. If the lens is dislocated anterior chamber, you can give miosis and go anteriorly and aspirate the lens matter. Usually they are clear lenses. Now you come to the secondary open angle glaucomas that can be caused by lens. On top of them is lens protein glaucoma, what is written in the textbooks, or still the terminology phacolytic glaucoma is a common name for this type of glaucoma. And here, as you see here, what do we call this? Morgagnan cataract. This is a liquefied cortex, and the lens, or the nucleus, sorry, went down by the gravity in this liquefied cortex. And it's a type of lens-induced angle, open angle glaucoma, described by Flock and Zimmerman in 1943. And Flock again defined it as a phacolytic glaucoma, resembling hemolytic glaucoma and other glaucomas that, due to the engulfing or the macrophagic response to the abnormal material in the anterior chamber, the macrophage engulf this abnormal material and gets swollen and obstruct the trabecular meshwork. However, later on, the situation is totally different as far as the mechanism. So the clinical picture, usually, this is one of our patients also, when I was 30 years ago or so, or 25. Usually the patient comes with pain, severe pain. Even as you see here, this lady has cutters, around the eye because of the pain, to relieve the pain. So it is very acute congestive glaucoma, and as I said, it is one of the emergency room glaucomas. High IOP in the 60, 70, even more, and poor vision, as in the phacomorphic glaucoma, sometimes light projection, faulty light projection, due to the pain and so on. Conjunctival hyperemia, corneal edema, and when you look to the other eye, you will find it is either aphakic or pseudophakic. The patient in a population like population in third world country, once they are moving around and they did one eye and everything is fine, they've neglected or they've forgotten about the other eye until they either to come with a phacomorphic glaucoma or with lens protein glaucoma. So usually phakic or pseudophakic. So when you again examine the eye, you will see mature or hypermature cataract, heavy flare. This is not a flare. This is a lens matter with a flare, with extensive protein, breakdown of the aqueous blood barrier, but mainly this is a heavy molecular weight lens protein leaked through the lens capsule. And sometimes you may see white patches like this. I don't know if it's clear or not. This is a macrophagic response trying to seal the hole in the capsule to prevent further showering of this type of protein. And when you do gonioscopy, you will find an open angle type. When we look to the diagnosis, as I said, it is most of the time it's not always to have a blown picture like this, but you can see a lot of abnormal material in the anterior chamber, calcium oxalate and so on, and this you will see like the ghost-cell glaucoma, you will find a very heavy protein in the anterior chamber and heavy abnormal contents in the anterior chamber. Sometimes, as we say, you see pseudohypopyon, as we saw a while ago. So what is the differential diagnosis? Acute angle-closure glaucoma, mainly the phacomorphic glaucoma, but the difference here, you will see the angle is, the chamber is different in both eyes, and in phacomorphic glaucoma, if there's a hypopyon or pseudohypopyon, you will not see it there. Neovascular glaucoma, again, is a very important differential diagnosis. Ghost-cell glaucoma, angle recession glaucoma, and uveitic glaucoma, all these are the possibilities, but believe me, if you use even a good clinical observation, good clinical examination, and the history and these things, you will be able to diagnose the condition. Although now it is getting less and less the presentation of this type of disease. Let us go a little bit to physiology. Regarding the lens protein glaucoma, to understand the mechanism, as Flock said that it is a phacolytic due to the macrophagic response, engulfing the lens protein, swollen macrophages, closing the trabecular meshwork. The lens protein represents about 33% of its weight, and 85 of this 33 lens protein, it represents a soluble protein, which is 85%, which is alpha and beta and gamma crystalline proteins, and the remaining 15% is albumoid or insoluble protein. So heavy molecular weight lipoproteins increases with age. This is studies has shown that when cataract formation, and mainly in nuclear region, absent infantile and juvenile lenses, and experimental studies showed that when we perfuse human eyes with a isolated heavy molecular weight lipoprotein, 0.5 milligram of this heavy molecular weight lipoprotein lead to severe obstruction, very severe obstruction. And if we increase perfusion, increase obstruction. So, and there is no swollen macrophages in this experiment. And irrigation with BSS, again, to wash out the material, or with alpha chymotrypsin that this enzyme used in the bath with intracapsular color extraction to dissolve the zenules so you can take off the lens, does not relieve the obstruction. So again, when they did the same procedure or same experiment with the low molecular weight lipoproteins, there was no obstruction. So this indicates that, yes, and again, to that also, to strengthen this outcome of this the experiment, engorged macrophagic after cataract needling in children in the past, they are not having this sophisticated management of cataract in children. They just go and puncture the lens, and the eye will take care of the residual lens matter and absorb the lens matter, and that's it. So no phacoritic glaucoma has been reported in children. And again, swollen rabbit macrophages failed to elevate IOP. The Duker has injected the retinal cavity of rabbits with silicone oil, and then, of course, there is the response, inflammatory response represented by macrophagic response, engulfing the silicone oil, swollen silicone oil with swollen macrophages with silicone oil, and he injected in the anterior chamber of the rabbit and didn't show any elevation of the intraocular pressure. So this is to say that, and this is again a paragraph to show how the heavy molecular weight lipoprotein increases formation with aging and with the maturation of the cataract. So it represents about 35% of total protein. That means 0.8 milligram in excess to the 0.5 milligram that we used in to do the surgery. And there is no heavy molecular in normal subject with mature or immature cataract. Although there are some reports that said mature cataract, you may find insignificant number of heavy molecular weight lipoproteins in mature cataract. So simple obstructions show the mechanism is simple obstruction of the trabecular meshock by heavy molecular weight lipoproteins, and this is the molecular weight of this lipoproteins. It's a giant molecules forming with time, with aging, about 150 multiplied by 6 times Daltons. So it is a large molecule. And macrophagic response, probably, it is not an obstructor. So they want to say that the macrophage is not the reason for elevation of the intraocular pressure. Maybe their presence, their additive effect, but the major problem or the main mechanism of pressure elevation is this heavy molecular weight lipoprotein, and they believe that this macrophagic response is a reliever, it's scavenger, khadam. They relieve, they engulf. You say, when they irrigated the anterior chamber with BSS, they couldn't move this heavy molecular weight lipoprotein. So when you remove the lens, as you will see later, and wash out, still there is a heavy molecular weight lipoprotein in the angle. So who's gonna remove it? Who's gonna clean it? Is the macrophagic response. And this is why in some cases, mild cases, that doesn't come with fulminating form of lipoprotein glaucoma, episodes of leaking of the capsule to the lens, heavy molecular weight lipoproteins, and the pressure goes up and subside. Subside by what? By the response of the macrophages, they engulfing the lens matter in the angle and clearing the passage or the outflow facility. So what I want to, my message in this issue, that this is very important in managing or planning or tailoring your therapy. In any case, you need to know what the underlying pathology is so you can tackle that underlying pathology, and this is the way or correct way to treat the pathology that you are having. So the problem is not macrophagic response. The problem is the heavy molecular weight lens proteins that reach the angle and obstruct the angle. So it's very important. Management simply, I would say medical, of course, medical treatment like neovascular glaucoma, like uveitic glaucoma, like many other types of that, they are not very helpful, you know. Admission, of course, important, but this topical and systemic medication may reduce the pressure from probably 70 to 50 or whatever, but they will never get the pressure down to an acceptable level. So, but it is good to optimize the eye for the different treatment by still, topical steroid, as hyperosmotic agent, anti-glaucoma therapy, and quieten the eye as much as possible. Then you go for cataract extraction with good, very good INA or irrigation aspiration for the anterior chamber, trying to remove all the material there, not already in the angle, because in the angle we cannot remove it. Who's going to take care of that is the macrophagic response. This is the most important way of this case. This is the same patient. I remember, I never forget this case. I found it even on the internet. This is our patient. This is probably now around 30 years with me, this slide. So this is faulty light projection, and here ended with 20/25 by simple removal of the lens and good anterior washout. Healthy disc, completely healthy disc, although she came with faulty light projection. Okay, then the other type is the lens particle glaucoma. This is, again, it's not as very much, usually follows bland or unbland extracataract extraction, penetrating lens injury, a new diamond YAG laser capsulotomy, all these which release the junks of lens matter that circulate in the anterior chamber and can block the outflow facility. So this is, one of our patients, you see that the lens matter here is very clear, and the lens will, if you leave it more, it will swollen and present as a phacomorphic glaucoma. So, yes, obstruction of subcutaneous meshwork by free lens material, inflammatory response, and the management is medical therapy, as we mentioned, anti-glaucoma therapy, topical steroid, surgical. You need to do anterior chamber washout and to remove the lens matter, simple like this. And then we come to the very common procedure that we do it on daily basis, which is the YAG laser posterior capsulotomy. And what is the its benefit, and we know what's its benefit, but it has some side effects, which is elevation of the intraocular pressure, which is the most common complication of this procedure, and acute, usually within hours, and then with time subsides, and magnitude may reach 10 millimeter above the baseline, and reported in 59%, but this is an old statement. I think with the new machines, the figure is not as this, and more than 40%, 40 millimeter of mercury occurred in 38% of cases. We need to be very cautious in interpretation of these. Yeah, I'm sure there is a better, although I did update my lectures always, but this one I didn't pay attention to it much. And even no light perception have been reported. I tried to find any report, but I couldn't, but it's written in the book, the textbook. And this is the problem, my explanation to that. Most likely, this is a patient probably with advanced, very advanced glaucoma, and he had probably YAG capsulotomy, a lot of energy, a lot of material released, and the patient probably not given, anti-glaucoma medication, and the IV is not checked 1 hour. This is probably the only explanation that I can say, yeah, it can happen, such a thing. So it is not acceptable for you in a glaucoma patient to do YAG capsulotomy and not to check the pressure after 1 hour. And if you see that the pressure is elevating, say 8 millimeter, 10 millimeter, you need to give extra medication or even to admit the patient and to observe him closely, especially in advanced cases. So sometimes, although as you will see later, we might need, but never happened with us, you may need to go and intervene in such a situation. So this complication is greater in glaucoma patient without IOL, and this is because the fragments can reach anterior chamber easily, more energy, of course, and so we need to measure the IOP, especially in glaucoma patient 1 hour post-op, post-laser, prophylactic anti-glaucoma before and after, topical steroids, and medical therapy, anti-glaucoma therapy, as of course, and hyperosmotic agent steroids, and surgical anterior chamber wash out, and you may need to go for filtering procedure, but honestly, I haven't needed such an intervention, or even anterior chamber wash out. So these are two eyes with glaucoma, both of them. What do you see difference in both eyes? What is the obvious difference with these two eyes? Huh? Hypopia, that's very good. What else? Good, one of them they have cataract. Okay, what else? Huh? This is very important. This is, ocomorphic glaucoma and gene-induced glaucoma. It is not that difficult if you examine the patient carefully. You'll find even there is no hypopia. This is not always you will see hypopia, or pseudo-hypopia, sorry. So not always. But when you look to the chamber, here it's very sure, probably even this is after BI probably. And here you see it is very deep. So it's very important. Small hints can give you a solution to or point you, or take you to the proper diagnosis. So, of course, both of them, treatment is the same or not? Why?
This anti-ptonia, and this is open.
Yeah, very good. So, what is the treatment in this case? No, different treatment. Huh? Cataract surgery here. Don't need more than cataract surgery. Even in the past, when they did cataract surgery, they compared both conditions, cataract surgery plus another group, combined procedure. And finally, they found the same thing. So you don't need here the glaucoma surgery. While here,
Yeah, you need PI and chemotherapy. You combine.
maybe or it's definitely. Huh?
Definitely.
Why? Huh? Huh? Exactly. So as we mentioned, this is a patient, yes, may not need trabeculectomy. So what we need is, as you mentioned, to do for a refractory to give the medical treatment, to give chance and other treatment, and to give chance to quiet them down, to look again to the history. How long the attack? How is the other eye? Is he already a glaucomatous patient probably, and this is aggravated by the phacoemorphic, by the lens size? So we need to manage it medically and then reevaluate the case and see, do we need to go for trabeculectomy or not? There is a big difference between lens extraction with and without trabeculectomy. You are adding a procedure. You are putting the patient at further risk of surgical intervention. So here, the same etiology, but in different mechanisms. Treatment is not necessarily to be the same. So we need to be aware about these things. Okay, so glaucoma due to... do you think that you have questions, or this is probably the most thing that I want to talk about? This is the most common forms that lead to irreversible visual loss in our community, although they are decreasing, not as 2 decades ago or so, but still, unfortunately, these forms of glaucoma, we see it from time to time. And I'm sure it is more common those who are going to المخيمات اللي هي في أفريقيا وأماكن أخرى, you will see more and more of these types of cataract and complication of neglected cataract. So Okay, I will talk about probably one thing, which is really, because I will give chance. This is my usual way to give time for discussion. I will talk about fake anaphylaxis. And I see even sometimes a lot of questions about fake anaphylaxis and so on. Is it an important issue or not? It's extremely rare. And yes, it is serious. And there is a zonal granulomatous reaction and KBs, and due to loss of tolerance to lens protein of the immune system, and usually you find that the typical granulomatous inflammation, but honestly, and I tried to find, it hasn't been or discovered in a living human eye, as far as I know. It is difficult to prove it. It's not easy to find, to diagnose it. So, but most of the time they're asking about fake anaphylaxis. It's not easy. It behaves like endophthalmitis, sympathetic ophthalmia, severe uveitis, and so on. But to be, when usually such a thing happens, usually the pressure will goes down due to the inflammation rather than up. So as far as from my reading, it never been in a major textbook by high authorities, never been diagnosed in a living eye. So it is in a cadaver eye after that. So, but still people are asking about it and so on. So as I said, resemble, as I said, sympathetic ophthalmia and ophthalmitis, toxic uveitis, and there are many KBs and so on. So in summary, yes, this unfortunately form of glaucoma induced by lens is a major cause or important cause of a reversible visual loss in our community and community of developing countries, and it is really need to be educate people that shouldn't leave the cataract until they get late. There is a conception in our population, old population, when I was a resident, that said that don't touch the lens until get ripe, otherwise the outcome will not be good. And this conception is decreasing now with the changing of, with the improvement of the education and so on. So lens-induced glaucoma, when we face a patient with elevated intraocular pressure in presence of opaque lens, cataractous lens, we need to think either the glaucoma either of open angle type or closed angle type. If it's open angle type, we have two possibilities, either pre-existing open angle glaucoma or a real lens protein glaucoma. Those are with open angle type. If it is closed angle, we should look to the anterior chamber. I did it myself, this one, but I'm sure it is missing many things, but this is to simplify things. So if the chamber is deep, we are most likely dealing with the pre-existing angle closure glaucoma. If the chamber is shallow, accelerated primary angle closure glaucoma or true thecomorphic glaucoma in shallow chamber. In very shallow chamber, either we are dealing with advanced, the chamber is very shallow, either we are dealing with advanced thecomorphic glaucoma or aqueous misdirection. So at this, I will stop and answer your questions or comments if you have. Thank you very much. Yes. Yeah, you can do it if the pressure is high. He said, do we need to do paracentesis before surgery if the pressure is too high? Of course, I know if you go to the literature, you will find that one of the management of acute primary angle closure glaucoma is to do paracentesis. If the AGBI failed or whatever, and I haven't need to do this or practice this thing. But if you are having the patient on the table with the pressure high, yes, you can, of course. It's always Always, even without high pressure. In my practice, we usually do paracentesis and decompress the eye very slowly. In high pressure, in high pressurized eye, yes, definitely. Otherwise, you will be in disaster. So you need to quieten the eye, to decrease the pressure, and before you open the eye, whether for ECCE or even for phaco or trabeculectomy. So you need to depressurize the eye, or definitely you need it. But as a major treatment or main treatment for acute congestive glaucoma, I'm not sure if I'm in agreement with this maneuver to do paracentesis. Paracentesis will decrease the pressure for some time, for minutes, or it's even 1 hour. So then the pressure will come back again. And now, when we do, after glaucoma surgery, when we do trabeculectomy, and the pressure after a few days high, and in the hospital, and we do decompression, and get the pressure from 30 to, for example, 10 or less, if you come at the end of the day, you will find the pressure is the same. So I don't think it's a maneuver that you can depend on it as a treatment of acute congestive glaucoma. Yes. قول معايا يا اسمع ايوه.
A patient with renal disease, like sometimes kids to give lens or
Yeah.
with paracentesis, treat way to swap.
No, whatever. And at least in my practice, paracentesis, I said, it is a momentary things, But when we need to give systemic medications, we need to look to is it contraindicated or not? So if it's contraindicated, we should avoid it. And but paracentesis will not be the solution that it will replace systemic medication at all. Yes.
Theoretically speaking, can you develop glaucoma in the setting of a vitrectomized eye?
In a vitrectomized eye? Well, that's a very good question. I'm not sure about that, but I will answer according to my imagination. Yes, if the lens is swollen rapidly, intumescent, or traumatized and swollen, yes, you can have it. But I'm not answering on a scientific basis. But it's a very good question. Mm-hmm. When you remove the cataract and lens of things from my eye, lens of things from that.
So you mentioned that the system in the eye, so
Yes.
are they accessible or not?
So the question is, when we remove the lens in lens of routine glaucoma, and you said that the material that is already in the angle, you cannot get it out with aspiration or so. Is it still going to cause glaucoma? Most of the time, you may have a glaucoma for a few days, but with, as we mentioned, the mechanism, the presence of a macrophagic response there will engulf the material and will take it out through the out-of-flow facility. So this is the aim, or this is the function of macrophagic response in lens of routine glaucoma. Their main function is to clean to seal the leak from the capsule, as well as to clean the trabecular meshwork from the abnormal material. Okay. You can relax before the grand round. Thank you very much.
Nice to see you.
Thank you. عبد الرحمن ايش؟ اوه كيف حالك ابراهيم؟ عبد الرحمن ده امتياز الحين ما خلصت؟ ها؟ باقي شوي؟ تمام كيف حالك؟ طيب شو الوضع؟ مدارس حياتك والامور طيبه وين شغال؟ وش شغال؟ ايه يا ايه وين؟
كيف حالك؟
زينة؟
الله عليك.
الله يعطيك
الله
العافية.
يسلمك يا رب. كيف حالك؟ الله يسلمك.
ليك احضاني دكتور انت فجوه هنا.
ونعم ونعم. الله يسلمك. على طول يو اس بي ها؟
يو اس بي
احسن من المشبوك على هذا.
احسن من تشبيك.
بس ما لقيت الباوربوينت هذه. في فيديو ما ادري ما اشتغل معي، ما ادري اشتغل معكم ولا لا.
نشوف يا اهلا وسهلا دكتور. حياك الله، كيف حالك؟
صورته ايه؟
الله يحفظك.
كيف نقفل هذه؟ بلاك في حاجه اسمها بلاك.
خلي الفيديو في الاخر.
الفيديو هو في الاخر.
احسن شغل اللابتوب بتاعك ده. شغلت بتاعك ولا حاجه؟
هذا حقنا يا دكتور اللي حط الفلاش.
وين ماني شايفه. لا فتح جديد. ليش فتح جديد؟ ليش كذا؟
امرني يا دكتور ايش؟
وين هو؟
خلاص قلت للدكتور لما تو هذا من هنا افتح روح ايوه روح من هنا افتح من الاول. جميلة ها؟ والله يا دكتور 10 سنين خلاص صرت كذا بتلقائي اندمج.
شوف عبد السلام قاعد فين؟
سلام يا ترجمان. زعلان.
لازم نقعد جنبه ده.
شيء ما يفتح.
دكتور واضح انها ثقيل. والله ثقيل ايوه طبيعي بيصير كذا شوي ما حط
عادي ما في مشكلة.
في فيديو واحد
شكل السلايدات كثير.
صوت
لا الفيديو كبير.
في بيج انيمال قافل حاطط فيه
أيوة. طويل هذا. في زرافة.
ياخد وقت.
عشان كذا ثقيل يا دكتور مع الفيل.
في زرافه طويله مطوله طويله.
راح تشتغل 100% راح تشتغل.
حطه كفايه. فلاش او تشغل له بتاع وخلاص، ولا ده ما يشتغلش. هذا ما يشتغل.
هذا يشتغل يا دكتور
عايز
بس-
كونكشن.
لا حيشتغل دايركت، بس حيشتغل معنا بس على البروجيكتور، مش حيشتغل على اربع شاشات. اللابتوب حقي لا حيشتغل على البروجيكتور والاربع شاشات. وشوي صالح الدكتور صالح شغلت له على البروجيكتور بس. لكن الاحلام اللي يكون لها ثواني دكتور اعطيني بالضبط دقيقه اشتغل
ان شاء الله.
ولا نشيل الفيديو من جوا، طب هو تقلوا الفيديو يمكن 4 دقائق.
شوف يا دكتور 87
يحسب. طب كويس، الآن بيحسب معنا كويس.
هتيجي اقول ما تقلقش.
استوى.
كمان دكتور اعطيه ثواني بس شوي ينكسر.
أخير بس هذا ما اشتغل.
شوف ايش مشكلتي. انت ايش الفيديو معك؟
الفيديو أنا حاطه هنا برضه، حاطه فلاش، حاطه على الفلاش برضه.
خلينا نسوي له سيرت.
شنو؟
استنى
اشتغل أبجريد في MP4 يعني. عشان ويندوز. طيب ما عندك الVLC؟
شغله على جنب برا.
هذا شغله برا.
برا حيشتغل بس حطه مكان واضح.
خليه هنا كذا زي ما انا حاطه برا. خش على شوف فيديو، اطلع شوف فيديو.
كل كذا عشان بعدين كذا بس اول حاجه هذا كله
الصور
رجع
كل صور. لا تلاقي يا فوق يا تحت تحت. VLC عندك VLC؟ طيب كويس.
موجود عندنا. تبي نشغل تجرب؟
6 2 3.
لسه ما استعمل.
الا فتح يا دكتور بس انه الفيديو الاخير ما اشتغل.
خليه
نشغل
لوحده.
سبريت.
بص انا شوف اخر.
طب ايش رايك اكنسله من الباوربوينت عشان ما يعمل تقل
لا
البرزنتيشن؟
خليه يا دكتور امشي ويدك بعدين
خليه
افتح
بره
الفيديو.
لوحده. خليه بره لوحده. سيبه.
VLC.
بس خليه سيبه.
اهم شيء في كنترول.
في ايش يا دكتور؟
كنترول لاني ما عملت له مونتاج صراحه.
انا حاضر شهور عندي عياده، انا بحضر شوي. ها
طيب جزاك خير، ما قصرت برف.
اي دكتور في تسريع قصدك؟ تسوي شو؟ خذ يدك انت يا دكتور شوف.
هذا سيختصر في العمل طويل. والله انا ما كنت مسافر وجيت ولا قعدت. شكل نخليه تحت عشان يسحب البوز.
الله يجزاك كيف حالك؟ كيف اخبارك؟ كيف
بعدين نفتح.
لا هنفتح
محمد رزاق.
اي بس انا قصدي عشان
بس خلينا نجهز.
وين راحت الباوربوينت؟
الباوربوينت هي نسويها من ماكس.
انت مسوي من مايس. اوكي ممتاز. ايش رايك نسوي كنسل الفيديو هنا؟
شيل السلايد كله.
إيه، شيل السلايد. لا شيل، خليها فاضي. لا شيل انكسر. اوبجكت ما ادري اضغط عليه. خلاص محمد باك سبيس. راحت.
خلاص ما هي.
خلينا بس اكتب فيديو. اكتب مثلا وين الليزر في هذا؟
الليزر ولفت رايت. خلينا نحط عشان برضه تجرب. خلينا نشبك نطلع.
طيب شغالة.
Bismillah ar-Rahman ar-Rahim. Today our grand round will be by Dr. Ihab al-Sirhi. Dr. Ihab al-Sirhi is consultant of ophthalmology, glaucoma division, King Saud University, and he is also glaucoma fellowship. Our talk today about road to safe phaco. I think what will come to your mind that you do phaco without a problem. Actually, we consider to be a safe phaco surgeon not only to do a phaco without complication, but to manage any complication happened. Dr. Ihab, you welcome here. We'll start now. Thank you.
Assalamu alaikum. Thank you, Prof. Thank you for attendance here today. You are most welcome for this station. Actually, this presentation will be a little bit quick presentation. It's not a classical presentation, just a few tips. Even not well organized for us, the classical lectures. Just for, some tricks and some tips during the surgery. What can you face at that time? So we start. So as we said, it's not a guideline for phaco. Guideline for phaco you can find in the lectures, you can find in the videos separated. But here just the tricks doing the surgery. This is just some things we noticed during working during the surgery, or while we are supervising others, or while we are learned from others also, our teachers and our friends and our colleagues. It's a drain of ideas, over 15 years in ophthalmology. It's a juice of thoughts, over 10,000 cataract surgery done by me. So liberate yourself from all boundaries of books and listen an open mind for some surgical tricks. And this is start. Here there is a small funny video explaining the confidence surgery against complication. A confident surgeon escaping from complication, but no way. Finally, the confidence and tricks, he can solve the problem. We start with Masbuti now. Start of all, when you start the cataract surgery, it is ideally you should select the type of anesthesia before you go to the surgery. Currently, with the much learned and educated patient and with the most confident surgeon now, we are going mostly for topical anesthesia. So most of the time we are not in need for the anesthesia people, who are our friends of course, but most of the time we are not in need for them in the surgery. But you should always select your patient, especially if you plan to go for topical. You should select that this patient can fit for topical surgery. He's cooperative. He will be stable for the type of the surgery. Will not move. Will not do any problem during the surgery. During the surgery, usually, as a classical, we are doing the peribulbar or sometimes the retrobulbar block, and we can add to that some extra epibulbar if you need. This is the classical bulbar. Sometimes you find, especially young patient, when you go for local, you need to do facial akinesia. Sometimes it's one of the method we used to do in the past with the ECC, and rarely using now, but it's still one of the valid option if you want to go for phaco and patient wasn't cooperative. And another issue here, as you see here in the second photo, the subtenon anesthesia is very nice option. You can sometimes you need to use it if you started topical. If you start topical and during the surgery and the globe already opened, you don't want to stop and to transfer for GA. So subtenon anesthesia is one of the nice and very, very useful solution in anesthesia. Of course, general anesthesia can be a choice sometimes in some patient, either plan from the start, especially in the young, or non-cooperative patient, or You can even need to go for general anesthesia if the patient is uncooperative during the surgery. The best approach. The approach either to be superior or temporal or superior temporal, whatever was. And you should choose your approach even, or you put in mind the approach for the patient before you go for the surgery. Now currently most people prefer to go temporal approach or superior temporal, but superior approach is also a useful approach, especially if you have a big number of surgery. You don't want to shift right to left every time. So this can govern by the type of the patient, the geometric of the face of the patient, the nose, the nasal bridge, the eyebrow, the sunken eye, like this patient has sunken eye, so difficult to go for any superior approach. Before adjusting patient, you should adjust yourself first. Of course, there's 3 more important points you should notice before you start your surgery: the table height, the chair height, and the microscope height. These 3 things should be adjusted before you start your surgery. And of course, you should give a very high priority to this issue, because this is relating to your health in the future, especially if you do a big number of surgery, very long time you are doing surgery. This is your main job, you are a surgeon. So you should be careful for these things. This is number 1. Number 2, if you don't adjust yourself, you will not be comfortable. You will not be able to use your legs and hands and your eyes at the same time simultaneously. You should adjust yourself to be relaxed, to be comfort, to be able to reach all the things which you want to do during the surgery, not to change during the surgery. Another point, for when you sit and you adjust everything, these 3 things, the table, the chair, and the microscope, you should adjust your hands. One of the most common things we are noticed while watching other doing surgery, especially the beginners, that they are not support their hands. They keep their hands just flight in the air and trying to go inside the eye while the hands flight. This is not good option, because when you do that, your hands will have some tremor, will have instability while doing the surgery. So fix your hand on the cheeks of the patient, or even in the eyebrow, or even in the arm support, but never keep your hands flight in the air. So very important to support your hands. As we said, if you don't support your hand, this can initiate tremor for you. You are a good surgeon, maybe you are a perfect surgeon, but tremor is something part of from us as a human being. If you have very fine-tuned things you want to do, and your hands is not fixed on a solid object, this can initiate a tremor. It's not a shame to have tremor, but the shame that you are initiate your tremor yourself. So try to avoid the things. Of course, there is something about talking about you drinking coffee. When you drink coffee, some people have higher chance of tremor. Not all people. Some people drinking coffee and doing the most difficult surgery without tremor. But the most important, not to drink coffee, most important than that, is to support your hand very well. Before you start, don't forget to have a look where is your legs, where is your foot is in. Look at the phaco machine which you are using, because phaco machine is different from one machine to the other. And even in the same hospital, even if you use the same machine type, you have many phaco machine, and the many phaco machine has many adjustment, and every adjustment has special function. Yeah, for example, if you look here for this is one as a sample. We has no financial interest with this company, but however, you should know which part this part for. For example, number 1 here, the left hip of the foot, it's used for continuous irrigation. In other machine, it's used for the reflux. You should know and test which one is for which one before you start your surgery, because if you have a surprise during the surgery, there is no time to think where is that for and where is that for. Okay? So watch your foot before you start. Be sure that everything under your control. Of course, you put your foot at the back and you control from here to float it. As I said before, you should adjust yourself, and your back should be straight. Like this gentleman, the surgeon one, and if he continue like this, almost he is old also, he will have big problem in his back. We don't want that for you, not for myself, of course. The patient, his also positioning is very crucial. You should avoid over-reflection as you should avoid overextension. Both of them is not good for the positive pressure, which mean to happen to the eye. Another issue, some patient has the tendency to tilt their head to the side of the surgery, and that will lead to the collection of fluid in the medial canthus, give you pooling and will give you blurred vision. And it's not good to stop surgery and re-correct the head. So be sure that the head is sitting well, relaxed, and he has the head support in good position. Very important thing while you are dealing with the instrument in the ophthalmology or other subject as a surgeon. All the instrument during the surgery should be being taught like a pen or a pencil. You are holding mainly by two fingers, your index and thumb fingers only. The third one, the middle finger, is for support. The fourth and fifth fingers are just to support your hand, not the instrument, support your hand. And never ever they should be as an obstacle for you. When you want to go inside the eye, don't make your fingers, the fourth and fifth, as an obstacle to you. You should give them away. And give way for the three fingers, main three fingers, to go freely inside and in, out and in. So holding the instrument is a very important issue, and especially when you're supervising someone who's doing surgery, it's not a secret that you are judging him from the first thing how he is holding his instrument. It's not a secret. Yeah, when you find the new one holding the instrument in an incorrect way, you give some impression about him. When you find him holding the instrument in the correct way, this is give you better impression about this one. And you can judge even how much far he will go for this surgery. So try to show us as how are you good in holding the instrument and how are you controlling your things. It's another point here, for the instrument. Always I notice this one while you are working the surgery and you have the surgical assistant for you, the nurse or the one assisting you. When you give the instrument, you should give by the back. Never give the instrument by the tip, especially when you are dealing with knives or forceps or something like that. If you give by the tip, this can give a risk for the one who is working with you. Draping the eye, it's a very important issue. The aim of the drape to cover the eyelashes away from you and to keep the area clean. If you don't cut the drape very nice way, may you have the lashes pointing inside the wound. So it's very important. For example, here when you cut the drape, this photo, keep most of the part in the upper lid to be folded later on when you put the speculum, to be folded under the upper lid, and that give you better cover of the eyelashes. Eyelashes pointing inside the wound is very irritating things and can carry some risk for the infection. When you do plan for incision, to plan the incision, be smart enough to do 2-in-1. Go for the steepest axis as much as you can. I repeat again, as much as you can. Go for the steepest axis. That will help you to reduce the astigmatism which the cornea has before. And this gives you 2-in-1. You correct the spherical power of the IOL inside the bag, and you correct any astigmatism in the cornea. The construction of the main incision is very important, and sometimes you need to do just small things, small tricks to give this main incision the superiority or the inferiority. As we said, as all you know, the main incision to be self-sealed later on should be at least biplanar or 3-planar. Should be multiplanar, more than one plane. When you go inside, you should go in grades. When you go, for example, first line, you go horizontal this way. So you little bit migrate in the stroma, then you go inside the AC. This is one of the choices how to have multiplanar. Of course, there is many choices, but this is one of them. Number 2, in a good form of incision, the entry should be radial, as if you are going direct to the center of the eye. not going to the superior or inferior part. Like this one, you are going inferior, so the wound will not be in same limbs. There will be instability and it will be oblique. The oblique incision has the chance to be leaking later on. There is also many things, we don't have much time to discuss all of them, but this is one of the most important. The side incision, as you know, is just a stab because it's small enough not to have leak, less than 1 millimeter. But be smart enough and make it a little bit long. Make you better seal. Sometimes you have good surgery, good main wound, but because of the very short side incision, may have leak from the side incision, and it can happen. Later on, when you go for the staining of the capsule, staining the capsule, of course, is not an important issue, but it's very useful in mature cataract, and you can do as a routine even in immature cataract, especially if you are beginner, just in case something happened, that you can find your way in the darkness. The staining the capsule give you good view for the anterior capsule if you want to solve the problem, especially if you want to do IOL implantations in sulcus place. So staining is good option in the start, especially for beginners. For the expert, they are using nothing, of course, sometimes even in the mature cataract, but it's a very useful technique. Sometimes also it's useful when you have the stain inside the eye, have some press gently on the sideboard to have some stain leaking from the sideboard while you're in the surgery. That will stain you the sideboard. When you stain the sideboard, it gives you less thinking where is the sideboard I put it. Sometimes you cannot see the sideboard because it's short tunnel. Sometimes you cannot find it. You try to go by the shoulder here and there, and you scratch the epithelium, and it's happened even with me, with others. And so that it's a good trick just to stain the sideboard while the stain is still inside. The capsulorhexis should be done with the least effort, because it's very small things you are doing, a circle of 5 to 7 millimeter. It's a not big issue. So it is nonsense to move your whole hand or even elbow or even the shoulder while you are doing the rhexis. Sometimes you find people doing rhexis and move all his body. We're doing rhexis. It's very short, only 5 to 7 millimeter, even 8 millimeter. You don't need to move than your fingers. Only move your fingers, and there is some capsulorhexis forceps or even the cystotome. It's a round body. Even when you rotate your fingers on the instrument, this will be enough to give you the function. No need to move all your hands. When you go for hydrodelineation and dissection, whenever there is possibility to do hydrodelineation, do it without hesitation. Hydrodelineation is very useful technique. It reduces the load for you, make your work is easier. Instead of eating all the nucleus content, all the capsule content, you are eating only the core nucleus. According to the age, of course, is it fetal, embryonic, or more than that. So when you have the chance to do hydrodelineation, do hydrodelineation. In hydrodelineation, there is a very important tip. When you direct the cannula through the wound, for example, through the wound, this is the main incision, should be the main incision. If you go, make the cannula directed radially to the equator, as if you are going direct to the equator. This is if you want to do dissection, not the other way. Don't go into the capsule and direct it to be like this. It will go to the equator and return back. This will not give you successful hydrodissection. So hydrodelineation and hydrodissection are very useful technique to separate the contents of the nucleus with minimum effort and minimum load. There is some cannulas which are very useful, like this cannula, which is flat tip. This is my favorite cannula, flat tip cannula, or the other name is Blumenthal cannula. It's very useful in doing hydrodissection. It's going under the capsule and doing very nice hydrodissection without effort. Make your habit always to check the stability of the bag after you're doing capsulorhexis to be sure there is no subluxation. Sometimes there is a mild or moderate subluxation, you don't notice it during the surgery. So make your habit always, before you do your surgery, you start to go for phaco, make little shaking for the capsule, for the content. I mean, you press on nucleus and you move right and left, check the stability. If it needs CTR, capsular retention ring, me need to, it's very severe, me need to convert to another procedure. But always check the stability. While doing the surgery, you want to start the phaco probe to go inside the eye. Always keep your eye on the anterior capsular rim. Of course, if the pupil is good dilated, you can see the anterior rim, especially if it is stain well. Always keep your eye on the anterior capsular rim. This is give you two benefits. Number one, not to touch the capsular rim by the phaco tip itself. Number two, to check the stability. But sometimes you have zeniodylisis while you are doing the surgery, and you are not noticing earlier. If you notice early, you can do something to solve the problem. If you keep it to the late, this will be very late. So always keep your eye on the anterior capsular rim. When you go for phaco, of course, the automatic setting of the computer, we have pre-phaco. Why we need pre-phaco? Pre-phaco reduce the load and reduce the burden for later on. Why? Because, you know, especially in the non-mature cataract, there is a lot of epinucleus contents over the surface of the anterior anterior nucleus, just under the anterior capsule. At that time, when you take it by pre-phaco. Pre-phaco sitting here has low power and low vacuum. You can eat easily without expending a lot of power inside the eye. Later on, while you are doing your phaco, are you pressing the nucleus, some contents of the epinucleus behind the nucleus will be squeezed from the back and the equator and will come again and will cover your tunnel if you do your tunnel. And this will build away. At that time, you have high power sitting in the phaco. If you eat this soft tissue by the high power, this will exert more power inside the eye and will endangering the endothelial count. The sculpt have very important point here. When you eat the nucleus by the sculpt, eat by the power of the phaco machine, not the power of your hand. You know, it's a sharp tip phaco tip. You can while you're pressing, you can eat, of course, but this will be against the stability and the safety of the zonules. So eat by the power of the phaco, not the power of your hands. This is a very important point. Of course, as you know all, the power should be minimum during the phaco tip is in the eye. So always exert power while you're going forward, no power while you're going backward. You reach the tunnel, you do your tunnel. When you start, power on. When you go back to reach the first point, power off. On, off. Don't keep it on always and go on up, forward and backward like this. On while you're going forward, off while you're going backward. Of course, the depth, you should go in enough depth. This will help you later on the next step in the cracking. Don't be hurry up, take your time. Better to do many sculpt away from the cornea, better than to eat them in the anterior chamber later on after the crack with the non-good crack. So good crack need good depth. Good depth need uniformal red reflex while you are doing your surgery. The cracking, whether you want to do 2 halves or 4 quadrants or even 3 pieces sometimes, the vector of action here, it's my idea, it's my thinking. It should be not always aside or aside and down. It should be aside and up, as if you are pushing the 2 halves up. So you go to the deepest point in your tunnel, and you push as if you are pushing up to the zonule. This will give you better, safe behavior for the zonule. You don't press down. If you press down, you're pushing the zonule down. So may you cut some zonules without you are noticing. So when you crack aside and up. This is my experience. Some people may have another opinion. It's okay, but this is my opinion. I feel it is the safest procedure you can do while you're doing the crack, especially in hard cataract. Hard cataract usually associated with some weakness in the zonule. As we said, be sure of the complete crack. Except in soft cataract, sometimes you cannot do the crack. So it's not a crucial point in all the phaco. Sometimes in soft cataract, you cannot do a crack in soft phaco. Now we're coming to the art of phaco. My opinion, art of phaco is the art of vacuum. Art of vacuum is art of vacuum. Power, any machine can do power. Anyone can do power. But not always, not every surgeon can do vacuum in good way. Vacuum in good way in the surgery, this is the art and the beautifulness of the phaco. In phaco, you have the ability to do vacuum. When you apply vacuum, you are cementing the part of the nucleus to the phaco tip. So you have the ability to control it wherever you want. This is the most favorable picture for me. This is the phaco tip, and as you see here, applied very nice vacuum. So the part of this nucleus is attached to the phaco tip and is cemented to it. It's part of the phaco tip. You can move whenever you want. You can move it in the good way. You can eat away from the nucleus, away from the capsule, away from the cornea, in the desired position you want to do it, especially in the iris plane. So if you have good vacuum, you have good phaco. It's not a matter of power. Power can be done by everyone. Just you press your foot and you will have the power you want. But it's not the issue and it's not the safe. But the vacuum control inside the eye, intracameral, you are controlling everything. We'll be back again to this point of vacuum. But just another point, when you're doing a cracking and you are trying to reducing the power exerted inside the eye, it's very useful to using the manual chopping. Manual chopping, of course, you know, we have the vertical when you're doing the chopping inside the capsule, endocapsular, and you have the horizontal chopping if you're doing in the anterior chamber while you are trying to minimize the power. You're just cracking by the power of the manual chopping. Of course, there is many types of chopping, but this is the main two types, the vertical and the horizontal. It's another point I have noticed sometimes while supervising some friends in doing surgery. When you do crack, be sure, especially if you're doing the horizontal crack, be sure that the half or the quadrant you are holding is all of it out of the bag. Either all of it inside the bag, you are doing vertical chopping, or all of the quadrant or the piece out of the bag. Don't keep half in and half off, half out. I mean, if you have, for example, half quadrant inside the bag, you're just pulling it, the tip, and you keep half inside and half in. When you do crack, there is much movement happen inside the bag, and the quadrant itself can injure the capsule, can injure the rim, and can affect the zonal stability. So either to do all the part inside the bag or outside the bag. Don't half in, half in. Don't do crack, especially when doing manual chopping. Vertical chopping has its beautifulness. If you have the cataract, you want to do cutting inside the eye, inside the bag. Of course, wise usage of the power is very important to the safety of the endothelial cell count. As much as you can use power in the less amount, use the less amount. And every machine of phaco are calculating the effective power time, EPT. After each surgery, there is calculation how much power you use during the surgery, how many seconds you use, how many percent you use the power while doing the surgery. Make it an interesting and funny thing for you. After you finish your surgery, go and have a look to the machine and see your EPT, how much was it. Of course, in soft cataract, it will be 3 less. In hard cataract, it will be more. So for you to train yourself to use the power less, always have a look to the EPT of yourself when you, how much I did this surgery, how much I use EPT for this surgery. It's just a rule of thumb for everyone. We should know. If there is no occlusion, there is no part of the nucleus closing the tip of the phaco, please don't do power. Doing power without occlusion mean risk. The radiation of the radiating power can reach to the capsule, can reach to the iris, can reach to the anterior limb. And this is number one. Number two, when you do power, you have more aspiration and may you have surge. So no occlusion, no power. This should be as a rule for us. Of course, unoccluded aspiration. You mean, yes, you are aspirating high and keeping aspirating without occlusion. No, nothing will come to you. Aqueous. This will reduce the pressure and can give you the risk of surge and surge mean rupture capsule most of the time. So to minimize the surge, there is many technique done by the factory. For example, to do the ABS system. ABS system is the small hole manufactured at the inferior part of the tip. Just if you have occlusion here, and with the sudden release of the occlusion, the continuous aspiration from this point or from this hole give you better stability for the anterior chamber, but not always. It's not 100% guarantee against surge, but it helps to make the surge lesser. So the best technique you do it, you don't do aspiration if you don't have occlusion. If you have occlusion, do the aspiration, wait for the build of the vacuum, and control your things. The ideal place of the phaco tip is in the center. This is the ideal place for phaco tip. Phaco tip should not go forward, backward, side, and left as much as you can. Keep the phaco tip in the center and control things by inside the eye, the contents of the nucleus, by two things. Number one, by the fluid, the flow which is coming from the two irrigating point from the silicone sleeve give you something like a wings. This can bring everything to you. No need to go and bring it by the phaco tip. Number two, you have the chopper. The chopper can help you to control things to come to you. Chopper can be an obstacle if you block the way of the fluids. Can be an obstacle. This will not give the flow, the free wave to come to bring things to you. So try as much as you can to make the fluidability the best solution for you. So you should be as a maestro of the orchestra inside the eye. Control things by the wave which is coming from the irrigating. It's your wings inside the eye. Your wings, see this photo, it's my favorite photo. This is the two irrigating flow coming from the silicone sleeve of the phaco tip, going inside the eye, especially like the wings of a bird. If you are inside and you have your things going inside, especially it's really like a physical wings inside the eye can bring everything to you. Why? Because the only exit in a good wound from the inside the intracameral space to go outside is the phaco tip. So everything will come to you without going to it. This is a very important issue. If you understand it well and apply well, it will save your time and save your effort. Always think in the irrigating flow as your wings for you inside. Of course, you cannot see the flow because the fluid, clear fluid, but it has the effect. If you change, you rotate the phaco tip right and left, and you see the wings are carrying things and bring it up to you from the bag up to the anterior chamber. Very important technique if you are using it the good way. So you are doing yourself more confidence in doing this technique and the surgery of the phaco. Of course, avoid the heat as much as you can, especially in the hard cataract. Especially wound burn is one of the things can happen if you exert a lot of power. When you come to the last piece, which is the most dangerous one, please take the chopper out, especially if you are using the sharp chopper, and put the spatula to protect the capsule. And you can bring the last piece to come to you from, especially if it's fallen down in the bag, bring it only by the flow of the irrigation, only by the flow. You don't need to go inside the bag by the phaco tip with the last piece to bring it. But you can bring it and bring the capsule. So be careful, put the spatula under it, and just control the flow to bring it to you. If you did a good hydrogenation, that you had separated the epinucleus from the nucleus, please try to keep the epinucleus to the last. Don't inherit. Of course, epinucleus is soft, can come to you easy, and you can eat easy. But if you keep it to the last thing, that can give you good support for the capsule to be away from you. It's engulfing the capsule from inside, so it can push the capsule away from you to the end of the surgery. So keep it to the last, especially if you finish the first half, eat the nucleus and keep the epinucleus with the cortex to the last, till you eat the second half, then you go back to eat the whole epinucleus together. When you come to irrigation aspiration, Irrigation aspiration is a good tool and a safe tool. You can even touch the capsule without fear of rupture the capsule like that, like the phaco tip. And you have some bend tip or angle tip, whether 45, 90 or even more, to reach to the sub-incisional area. So it is a good tool to have irrigation aspiration. But always remember, while you are doing irrigation aspiration, there is a function in the phaco, its name is reflux. Because accidentally, you can capture the capsule and you have the star sign, the indentation of the capsule. At that time, you should use the reflux. The reflux in the phacopedal, when you hit the reflux, you will have a gush for the whole content inside the tubing system of the phaco. So always remember that you have gush, and because when you started, you know where is the phacopedal sitting. The gush right, the reflux is right or left. You know that you can use it at that time. So that I said in the start, please know where is your foot is in. There is one more thing. In irrigation aspiration, think about the bimanual irrigation aspiration. It's very important and useful tool. If you find it in the OR, you can use it, especially when you stuck in some cortex in the subincisional area, and especially it was significant. Sometimes you can leave it if it's not significant, but this of course can lead to some PCO chance. But however, if you have the bimanual irrigation aspiration, it's very nice and very useful tools, especially if you have this one, like this one, which has polisher at the tip, and you have some fibrotic tissues and the posterior capsule. IO implantation, of course, is far easier than before. We use the forceps. Now it's already coming preloaded. Avoid touching the center of the IOL. The IOL can be scratched if you're touching the center. Don't forget figure 0, Zoro. Zoro, that means if you imagine, this is the optic and this is the haptics. Always should take this shape inside the eye. The IOL, not to put in the reverse position, should always remember this Z shape. Don't forget it. Sometimes you implant the IOL in the reverse position. If you put the IOL inside the eye, you should always respect the direction of the haptic. So you should dial in the correct way. The correct way is the green or blue? Green or blue? The green, should be the green. Of course, if you have the optic size smaller than the capsulorhexis size, better to use the constricting medicine like myocol or myostat, carbacol, whatever. At the end, when you want to close the wound, only stromal hydrate the wound itself. Don't hydrate the whole cornea. Don't hydrate the cornea till to reach to the center of the cornea. Only hydrate around the wound. And every wound has two edges, two limbs, the one here and one here. You should hydrate both ends, and sometimes at the center, but don't hydrate up to the center of the cornea. Lastly, when you remove the speculum, please be gentle, and be sure after you remove the speculum that the S is still filled. Yeah. Be sure always that the S is still there. And sometimes while you're pressing the speculum and you press the cornea or the wound edge, may you have some leak without units. So after you remove the speculum, also have a look to the eye. After you remove the speculum. While you remove, be gentle, and after you remove, have a look again to the eye before say to the patient, Alhamdulillah, salama. We have a small video, 1 minute. We have a small video, I don't know, there is time. We try just to have a look. Actually, we didn't have time enough to cut this video, so it's full video. Inshallah. ما اشتغلت ليش؟ ازرق في ازرق، احنا كنا مشكلة. Okay. تكلم. Just a quick phaco for some soft cataract. It's here, this patient we plan to do for topical anesthesia. Unfortunately, the patient is moving her eye so much. Yani whenever you touch the eye, she's moving right and left. She was not so much cooperative. But however, the phaco done here. This is the staining of the capsule and the bubble. Then cleaning the capsule. This is the sideboard. She's moving her eye. So we try to fix the globe before we touching inside. Little tunnel of the sideboard will be useful later on in the stromal hydration. Then we do the rexis as quick as possible. Again here. Now we'll do the hydrodelineation. Now see the golden ring happen. There is golden ring. You can see the golden ring here, which is the characteristic of the hydrodelineation, which is very useful in the soft cataract. After that, while doing the hydrodissection, what happened? Actually, the whole content spilled up in the anterior chamber, or actually not the whole, only the inferior pool. And because it is soft, you cannot replace back again. So what was the plan now to do the surgery? To do completely intracameral. It's a soft cataract, and now if you try to push it down now, it cannot go. You try to rotate, cannot rotate. It's just stuck like this, half in, half out, which is something we don't like because it's endangering the stability of the zonules. So the decision just now, see here, this is the inferior pool. This is the inferior pool, actually, sorry. This is the inferior pool of the nucleus popped up in the anterior chamber. And we have the nucleus here because we did the hydrodelineation. So there is no strict rules in the phaco. While you're doing the surgery, many things can happen which you don't expect it. So always customize yourself to what happened. This is another useful technique where you are trying to apply vacuum and nothing can be holded. You can shake your hand. The shaking your hand or crocodile technique, shaking things inside, make some stability. Now see this point, the nucleus have been eating because we did good successful hydrodelineation, so the nucleus came. Now there is no nucleus inside. All these contents are epinucleus and easy to eat epinucleus without endangers anything. See, just a matter of 1 minute or less than that. After that, it's a good thing that, as I told you before, the bimanual irrigation. This is bimanual irrigation. It's very useful in eating things, the cortex and epinucleus, very quick, and doesn't take time. And you can reverse. You put the irrigation from the main or the other side, and you aspirate the aspiration from the other word, which is very good advantage in the bimanual. When you finish everything, eat all the cortex, clean everywhere, and polish the posterior capsule to be bright and clean. Nothing left inside. Then bright capsule from all the sides. And then after that you put the IOL. As I said, it's an easy issue now. Always we push the IOL, as you said, remember here, the direction of the zonule, the Z shape, Z letter, and try to push away from the center. And if you push, try not to use the tip of the Siniski. Try to use the side. It's less traumatic and less dangerous for the material of the IOL. After you put the IOL inside, and you clean the viscoelastic by the manual again, control things, large pupil, stromal hydration around the wound. This is one of the disadvantages of the bimanual, that you have two main wounds, two side boards, the here and there, and the main wound here. And this is the end of the surgery. And the presentation here finished at this point. And thank for your listening.
Thank you very much, Dr. Ihab, for interesting topic about FECO and to be safe in your road. Before we open the floor for discussion, I want to ask you, what about beginner for FECO? There is some people, they have opposite to what you mentioned, overconfidence. You think this will affect the result in the road?
Wallahi, my convince is overconfidence is more harmful than underconfidence. But listen to me. But overconfidence in show is very good and useful. Show that you are overconfident, but don't be overconfident. Convince others that you can doing with things very nice and deal with it safely. But when you go to the real situation, don't be overconfident. Be slow, don't be in hurry. That's number one. Number two, whenever you feel there is a stuck point, don't hesitate to ask for help. People around you to help you and to have the safety of the patient. Never hesitate to say, I think there is problem. I think it's enough to call for help. Be safe, be under confidence in work, but show that you are overconfident. This is my advice, and this is what I have to use to do.
So we are lucky today that Prof. Saleh Al-Amr is here. He is my teacher for FECO. The first FECO I assess. When I start to learn FECO, he is the one who teaching me how to do it. We can open the floor for discussion now. Provide Prof. Saleh.
Bismillah. Thank you very much, Bihab. I think this is very interesting overview and basic sort of steps. And I have a few comments. First, I found that you probably just in the picture that you irrigate do hydro irrigation or stromal hydration for every wound, or just when there is a leak? Because once you do the sort of the leveled incision, most of the time there is no leak by the conclusion of surgery.
For the sideboard.
Even for the main port.
Even
for the main port, if you do, as you have shown, 3 levels. Correct. Or even 2 levels, just check if there is a leak, and there is even, sometimes you can press on the anterior lip and the leak will stop, or if there is a continuous leak, you can hydrate. The side port, I saw that you are doing it a little bit more posterior. And closer to the root of the iris, you will have more iris prolapse from the side port, yes. Especially when it is a little bit larger than, and we are using the chopper, which is a thin sort of instrument. So if you do it a little bit anterior, I usually go around 2 millimeters or so. This will make your life easy, because sometimes with this you will have atrophy of the iris in that location, and if it is on the either side horizontal, the patients might be bothered by the light or rarely diplopia. But overall, I think this is a very nice presentation, and I congratulate you.
Prof. Saleh, thank you for comment. Actually, I totally agree. If there is no leak, you shouldn't need to do, you are not in need to do the stromal hydration. And I think there is one study about the comparison between the eyes which have been done stromal hydration and no stromal hydration at 6 months. He found there is some difference in the visual acuity, better for the corneas which had no stromal hydration. But of course, it wasn't significant. However, try not to over stromal hydration. This is the main issue. If there is no leak, of course, no need for stromal hydration. For the sideboard, usually it is stab. Usually there is no leak, but sometimes even from sideboard there is leak. And as you said, it's better to go centrally rather than to go peripherally. Totally agree with the Prof.
Point you mentioned about when there is astigmatism. Usually, from the geometry of the cornea, the peripheral 3 millimeter incisions, they usually don't affect the yes. Sort of the astigmatism. So don't rely so much on handling the astigmatism with our incisions. But now, if there is more than 1.5, most of us will go for toric, as you know, IOLs, which will correct the astigmatism rather than using glasses afterward.
Yeah, it's okay. Of course, it's one of the choice for the astigmatism correction is the toric IOL. Our school, you are using toric IOL for the high astigmatism. Before that, there is many steps, either to be try to go, if you have real astigmatism, you should go central more. One of the slides showed that if you go centrally, you will have more effect on the astigmatism. If you have 0.5 to 0.75, it will give you a good correction for that. Of course, 0.75 itself is not a real significant thing for the patient post-operative. And it can help even, especially in the minus, can help in the reading if you have correct emmetropic patient. But if you want to remove all of the astigmatism, you go a little bit central, and you can give adjunct limber relaxing incision also by the same keratoderm of the special knife of LRI, and this will give you better control for the astigmatism, especially if it's reached above 1 diopter. Sometimes it can give you correction up to 1.5 or up to 2 diopter with the limber relaxing incision, both of them. Toric IOL is one of the best and nice and most perfect things to have for the IOL implantation.
What's your limit to use toric IOLs?
Toric
yourself?
above 2.5. Yeah.
It's a little bit too high because,
Yeah.
in fact, we were doing a course and he was asking how many cases that you place toric. Most of us, we were in the vicinity of 20%. He said that it is very low.
Yeah.
Now they are trying to introduce toric IOLs even in general hospitals, so that there will be no residual much of astigmatism.
Yeah, of course. One of the best solution, of course.
اوكي تفضل دكتور.
Usually explain very nicely how to do a good phaco. For example, each step we know that everything can happen wrong. Each step is important. If, for example, if you have Argentina flag and you have extension, do you continue with phaco or you convert to
Convert.
ECC?
Yeah.
This is the first question. Second question, when do you decide from the beginning this eye is better to be done by ECC rather than phaco? Thank you.
When, thank you for your questions. Very nice question actually, but have a lot of answers. Especially if you have Argentina flag or as general, if you have an extension of your capsule rhexis. A general rule, 1 point of weakness is more dangerous than 2 points. 1 point, and for example, if you have extension for the rhexis in 1 point, it is more dangerous and more amenable to extend beyond the equator and reach to the posterior capsule than you have 2. You have 2 or 3, this gives you less stability. And don't forget that the phaco, when it started, there was no capsule rhexis at that time. They started with the can opener technique. The phaco started with the can opener, then they discovered they invented actually the capsule rhexis, CCC, capsule linear. So it is not a contraindicated to do phaco, even with the extended wound, but be sure and be very careful, and your eyes this time should be very touching the periphery, especially if you have good dilatation, you can go and proceed. Especially sometimes of white cataract, the nucleus itself is not hard. It's like chalky, like a tabashir. It's very, very easy to eat it and soft without pressing. So you have Argentina flag, to have 2 extension points. You can complete phaco safely without any problem, but you should be very careful and reducing the bottle height, reducing the vacuum, the aspiration flow, reduce all the parameter and do it. It's very simple. If you feel any risk or any instability, better to do ECC than to say sorry later for the patient. ECC nowadays, we keep it only for the one of 2 things. Either subluxated IOL or unstable place, not IOL, sorry, the lens, subluxated lens, unstable. Better to do ECC than to do phaco, and you have the risk of nucleus drop. And go for the colleagues of the retina, please take this nucleus for me. Better to go for ECC. Or if you have low endothelial cell count, cannot afford the high power which will use, and you have hard cataract inside it. So if you have one of these 2 parameters, you have the ECC. Nowadays, there is very nice solution between the phaco and ECC, which is the small incision. Especially for the people who are going for India now or going to Africa, there is very nice technique of doing small incision cataract surgery safely, and it's doing exactly like phaco because it's sutureless, and you can keep it for the things which you have risk for the endothelial cell count, but not for the subluxated lens. Small incision is not good for subluxated lens. It's because it's closed compartment, especially exactly like the phaco. So it's not good to do for the subluxated or the weak zonules. Better to go for ACC at that time. So unstable zonule need open compartment surgery, not closed compartment surgery. Other things can be done under closed compartment surgery like phaco or small incision.
You can add also corneal scar. Yeah. Don't forget we have a lot of patients. Even minimal corneal scar can disturb you when you do phacoemulsification.
Sure.
And it's very important to have the decision before you take a patient to OR. It is not a shame. Sometimes the result of ECC is better than phaco.
Exactly.
Better to decide before. If you feel that this is unsafe, better you go for ECC.
Isam, just comment on your comment. The scar, I found also when you have corneal scar, very useful to have the fiber optic of our retina and if close to the limbus and from the side. This will give you
Good view.
quite good view. Regarding when you have extension, when you want to fracture the nucleus and there is an extension, make sure that you don't fracture the nucleus in the direction
The
of the
same,
extension.
yes.
This will most
Avoid,
of the
yeah.
time will
Yes.
give it into, will take it into the posterior capsule. So it is fracture at 90 degrees, and this will not put any stress on the
horizontal.
extension side. Regarding if you have a drop, which can happen, especially when beginner, if you have a colleague in the OR, a retina colleague, ask him to come. And you can do it at the same time. In fact, we are preparing to publish simultaneous BBV and fragmentation of the nucleus in the vitreous, along with the dropped nucleus in
At the
the
same time.
same setting. And this will quite save the patient from another surgery, and you can do it quite easily, of course.
This
And
is,
even if you are under topical, you just infiltrate with the subtenon,
Subtenon.
and this will be quite effective. And this procedure usually is quite quick for the retinal
Yes.
surgeon.
Of course, if you have the retinal surgeon who has the good time to go for extra surgery, it will be very nice option.
one of our nurses, she did phaco. I asked her, why you went for that man, X-man retina? Don't come to us. She told me, because if the nucleus drop, he is the one who can take it out. Any more questions? If no more questions, thank you very much for attending. There is quiz, yeah?
No quiz today.
Okay,
There's
thank you.
other course. Thank you. Thank you very much.
Well done.